For the lateral projection of the chest, once again, we want to ensure that we have a minimum SID of 72 inches to decrease the magnification of the heart and increase the recorded detail of the thoracic structures. When positioning the patient, turn the patient into a true lateral position. Most commonly, use the left lateral position with the patient's left side against the IR. Have the patient extend the arms upward. In this image, you can see the patient has their elbows flexed with their forearms resting on their elbows and their head. If the patient is unable to perform this position, place an IV stand in front of them. This is also helpful for unsteady patients. You can have the patients extend their arms and grasp the stand as high as possible for support. You want to be sure to adjust the height of the IR so that the upper border is approximately 1.5 to 2 inches above the shoulders. Direct the central ray perpendicular to the center of the IR. The central ray should enter the patient at the mid-coronal plane at the level of T7, or the inferior aspect of the scapula. Be sure to use an exposure made at the end of the second full inspiration to ensure maximum expansion of the lungs. When evaluating the image, the following should be clearly shown. There should be evidence of proper collimation. There should be superimposition of the ribs posterior to the vertebral column. The arm or soft tissues should not be overlapping the superior lung field. The sternum should be lateral with no rotation. Be sure that the costophrenic angles and apices are included within the lung field. There should also be proper penetration of the lung fields and the heart, with sharp outlines of the heart and the diaphragm. And finally, the hilum should be located approximately in the center of the radiograph.